Hello, my name is Isaac Salamanzada. I'm going to talk about COVID-19 disease and pulmonary vasodilators in particular and their possibly adjunctive utility. Uh, we're going to go through different studies briefly and try to learn from them. This is the first. Here we see that vessels that are markedly small are decreased. These are blood vessels less than 5 millimeters. Uh, their overall volume is decreased when in over 100 high resolution CT scans of patients with COVID-19. Vessels are decreased and the large vessels are increased. Just showed that patients who are on these vasodilator medications had improved survival, and inpatient, these were medications that were administered to patients during their hospitalization. Whereas the big data is outpatient, a review of electronic medical records. The viewer can judge for themselves. This study also looked at calcium channel blockers and the infectivity in the epithelial lung cells. It's just to mention that it's not only the vasodilation that's at play, but apparently these medications also affect the actual infectivity of the virus. So let's go further into pathophysiology. This is an interesting study that looked at vascular endotheliitis in angiogenesis as well as thrombosis in COVID-19. If your vessel's not patent, the perfusion will not flow well, and that is a recipe for microthrombus development. Here's intussusceptive angiogenic features. That's markedly, significantly different than patients with influenza. Here as well, intussusceptive angiogenic changes with time. This is really interesting since the hospitalization in days, you can see 0 to 10 days, how much that just shot up, the angiogenic changes. And this is something that clinicians who are at the bedside can relate to, in that patients in one day they might be saturating at one level with a certain amount of oxygen supplementation or supportive intervention, and then the next day they might need more, and the next day they might need more until, God forbid, there's a clinical demise. So this is really something to take into account. This is further compromised microvascular integrity. You can see how nice this network is and how compromised this one is. It just goes to show you how the microvascular perfusion and integrity really plays a role in COVID-19 disease. Now, remember that first study we showed with the microvessels? Well, the same group found that patients who had less blood volume in their small vessels, they needed more oxygen. So that's a clinically hospitalized COVID-19 patients. You can see that patients who needed more than 2 liters had significantly lower BV5, which is the pulmonary vessels that are less than 5 millimeters in size, versus the patients who didn't need that extra oxygen supplementation. So they concluded that pathologic alterations in the pulmonary microvasculature played a role in the impaired alveolar gas exchange, and they suggested therapeutic strategies in this phase of the disease should therefore focus on addressing these changes by way of what? By way of vasodilators and antithrombotic strategies. The two really go hand in hand because vasodilation can allow for more flow. Antithrombotic agents can allow for can detract from clot development or thrombotic development. So they're really two sides of the same coin in a certain sense. And again, this is the clinical study that showed improved survival we mentioned earlier and decreased need for intubation in patients that were hospitalized. So what they suggested seems to be consistent with this inpatient population from Brooklyn, New York. Now, the other question is, what about the VQ mismatch? Would this mess up the shunt? Would this even cause a worsening of oxygenation? If you vasodilate, hey, doesn't that go against the the homeostatic mechanisms for hypoxic pulmonary vasoconstriction that sends blood flow to the preferential regions where more oxygenation and alveolar exchange is in effect? Well, that is a legitimate question, but in this pathologic disease where a diffuse process is at play, that mechanism, that homeostatic mechanism, may not be effective. It may be counterproductive. Of course, more needs to be studied, but this is another study that created a mathematical model to investigate what is going on with the VQ mismatch. And they found that the reported severity of hypoxia in early COVID-19 patients could not be replicated without considerable reduction of vascular resistance in the non-oxygenated regions. They basically suggested it provides evidence, their model, that the amount of shunt observed in patients with early COVID-19 is not plausible without hyperperfusion of the relatively small fracture of injured lung, with threefold increases in regional perfusion to afflicted regions. So this is their model from that study. Just to relate, if there's a place with decreased aeration, that should send blood flow to the well-aerated regions for improved perfusion in the upper, middle, and lower lobes. Here, this is hypoxic pulmonary vasoconstriction. It can be reversed in this model, that the impaired regions could have increased perfusion to injured regions, like you see here. Their conclusion was that notwithstanding other systemic effects of pharmacologic interventions, our model suggests, that's the authors, that vasodilation throughout the non-injured lung may counterbalance disease-induced vasodilation in the injured regions, restoring a more uniform baseline perfusion distribution similar to the impaired HPV model. Vasodilation may also reduce the severity of thrombotic pulmonary emboli, thereby reducing physiologic dead space and perfusion heterogeneity. They also relate it to supine positioning, and they suggest that pulmonary vasodilators and prone positioning may improve ventilation to perfusion matching and reduce hypoxia, providing palliative care, not in the sense of improve outcomes in patients with COVID-19 disease. So their mathematical model basically says that, yes, there is something to be studied here with the VQ mismatch, but in their overall assessment, pulmonary vasodilators would do more good to improve outcomes based off their investigation. So now we're just going to switch gears and just look at, aside from direct vasodilators, we're going to look at cofactors that play a role in the vaso responses to dilation. And you'll see what I mean, that, for example, serum iron levels is shown to be a predictor of coronavirus disease severity and mortality. Now, just give me a minute. Why would iron play into this? Just first recognize that severity and mortality of disease is closely correlated with serum iron levels and iron concentration as an independent risk factor for death of COVID-19 patients. Now, aside from all the infectious disease aspects of how iron plays a role in infection and propagation and such, we're just going to focus on one angle, that angle being the pulmonary vascular response. Okay, I'm not suggesting that this is the only thing that iron does, but I'm just focusing for 1 minute on that angle. Okay. So, for example, the increase in pulmonary artery pressure caused by hypoxia depends on iron status. So iron plays a role in pulmonary artery pressure. Again, iron can play a role on many other aspects of this disease that are beyond this talk, but I'm just focusing on the pulmonary artery pressure and the vascular response. So, for example, intravenous infusion of iron showed that this is an acute hypoxia. The pulmonary artery pressure generally will increase. With iron infusion, that response doesn't allow for an increase of pulmonary artery pressure as much without iron. Response. This is a side point. Impaired cardiac function is associated with mortality in patients with COVID-19 infection. This is 123 patients. And talk about some other cofactors like vitamin C deficiency. This is just a case report. But they also found that the oxygen-dependent, the hypoxia-inducive family coordinates the body's responses to hypoxia, and its activity is regulated by oxygen-dependent hydroxylases, which need vitamin C and iron as cofactors. Deficiency of these cofactors could lead to uncontrolled hypoxia-inducive family activity and pulmonary vasoconstriction, responsive to vitamin C and iron administration. This is from Chest in 2012. Again, that's just another couple cofactors, and here's vitamin D. Anyone who's been following COVID-19 has known that also vitamin D deficiency is associated with differences in outcomes. Well, vitamin D replacement therapy in patients with pulmonary arterial hypertension is a separate condition, but nonetheless relevant and something we can learn from. Vitamin D deficiency results in significant improvement of right ventricular size, and mean pulmonary artery pressure improves non-significantly. So this is playing a role. These are different cofactors that also contribute to the pulmonary vasculature. You can see here the relationship between vitamin D deficiency and pulmonary artery hypertension. Systolic pulmonary artery pressure of patients in the low vitamin D group was higher than control groups. And again, this all goes back to the microvascular perfusion that's at play, not the macro, but the micro. And again, it goes back to this ventilation perfusion perspective. I mean, what we've been doing so far is focusing on the ventilation. We give them not only supplemental oxygen, but we'll give BiPAP, we'll give high flow oxygen, we'll even intubate the patient and ventilate them. But that is just focusing on the ventilation. It is not. It is playing. It is. I don't want to say ignoring, but paying less attention to the perfusion of the alveolus. One of them needs to take, the other needs to receive, and you can't have one without the other. You need two to tango. And if we're doing everything possible to improve the ventilation, but we're neglecting to appreciate the impediments to the perfusion, we're doing ourselves a disservice. We have to recognize how important perfusion is. In fact, the two drugs that have been shown to improve outcomes, particularly and highlighted, are dexamethasone and anticoagulation. Well, both of them, dexamethasone can help decrease the inflammatory markers and the edema, inflammation in this region, and allow for improved diffusion across the membrane. Well, that's one aspect, but the anticoagulation also focuses on the perfusion, decreased thrombotic development. Those have shown improved outcomes. Ventilation, you can see other studies that show patients are ventilated, many of them, the majority of them did not survive. So we have to rethink it. We have to rethink our approach and appreciate how perfusion can contribute. Again, rebalancing perfusion to oxygenated areas like we showed in that mathematical study. So if we just review this, we think about COVID-19 disease, and there's a viral provocation, there's inflammation, usually with edema formation, and there's hypoxic vasoconstriction. And then there's also compromised perfusion, particularly in microperfusion and thrombi development. And once we reach to that level, then patients it's very difficult to help them to recover when the thrombi have already taken hold. And this is a scheme to consider this trajectory and the pathophysiology with worsening hypoxemia and respiratory failure. Anyone who's been taking care of patients who are hospitalized with COVID-19 and ill, many of them can have worsening hypoxemia and respiratory failure as they go about as time passes with their hospitalization. Like we mentioned earlier, the angiogenic development. So first, there might be compromised diffusion and edema formation caused by viral provocation, immune response, and inflammation. Well, this is where steroids can help. Later, there can be vasoconstriction and compromised perfusion, alveolar capillary unit flow impedance, that's the constriction, heterogeneous perfusion, hypoxic pulmonary vasoconstriction. This is where vasodilators might help. Thrombosis development is more towards the end, at least you might consider that. Endothelial injury can occur, hypercoagulability, and microclot formation. There's microclot, like we showed earlier, and this is where anticoagulation can help. So anticoagulation and steroids are already recognized. Vasodilators are not, and this is what this talk is coming to promote. The further consideration of vasodilator therapy as adjunctive treatment in COVID-19 disease. Perhaps we need to investigate more the role of vasodilator therapy and see which ones and how they might be most effective. So again, this is the worsening hypoxemia, and these are correct counteractive treatment strategies. Again, the conclusion is steroids and anticoagulation that we already mentioned are something that are already more or less accepted. Calcium channel blockers have not, I don't think, have received enough attention, and that's why that's what this talk is coming to promote. Vitamin D supplementation, vitamin C supplementation, I mean, certainly as cofactors, like we mentioned earlier, from the perspective of vascular responses. Obviously, these cofactors play larger roles in the physiology and responses to infection that on multi-organ systems that are not mentioned in this talk, but it's just focusing on one angle, and that is the vascular response, particularly anything that can promote and improve microperfusion along the alveolar capillary unit where oxygenation occurs. Anything that can promote that should, at least in my perspective, help improve outcomes in patients with this disease. Intravenous iron, even though there have been articles that have talked against using iron in patients with COVID-19 disease from an infectious disease standpoint, I don't know. I don't know the answer. I'm just throwing this out there because I suspect that these might be actors on this stage and things that we must consider. Aminophylline is another vasodilator, phosphodiesterase inhibitors, adenosine. Other pulmonary vasodilators can also be considered. Even nitrous oxide, which has been touted, may be studied. But I might add that nitrous oxide needs to be, if it's inhaled, it has to cross the barrier, the fusion barrier that might be compromised by the inflammation and edema. So intravascular vasodilators may be a more efficacious route, but that remains to be investigated. I just wanted to share these thoughts, and I hope that it leads to better outcomes in our patients. And if this information is incorrect or misguided, I hope that it's rejected, and I hope that it's not adopted. I don't want to cause any harm to any patients or anyone. I'm just trying to share information that, from my perspective, plays an important role in COVID-19 disease, and I hope that it helps our collective efforts. Thank you very much for listening, and take care.